Hello, my dear students. I hope you're having a great day. This is Dr. Anaya Kulkarni. I'm here with you, your Pedodontics guru, and I'm here to take a session on the most important questions for INI-CET exams. Okay, so without wasting a lot of time, let us begin with the most important questions that you need to go through or that will make you brush up a particular important topic for the INI-CETs. Okay, so most important questions for the INI-CET exams. Let us quickly jump to the first question that I've selected, and that is the first question says trauma caused intrusion, and the amount of intrusion that has been caused is been mentioned, that is 4 of intrusion has been caused in the maxillary central incisor with the root shifted labially in a 4-year-old boy. What should be the treatment? So the first thing that should come to your mind is that this is a socket, for example. So this is a socket. There is a permanent tooth bud over here. There is the primary tooth, just like this. Sorry for the horrible diagram, but this is the permanent tooth, and it has intruded. What they've said is it has intruded 4 inside. So it has intruded 4 inside, and such that the root has come labially. So the tooth must be looking something like this. So the tooth has gone inside 4 and the root has been tilted in the labial or in the forward direction. So what all you need to be focusing on this question is there is intrusion that has been caused. It is a 4 intrusion of a primary. So primary you'll get when you see that the age of the boy is 4 years old. So it's a primary maxillary incisor. Okay, the age of the boy is 4 years old and the root has been tilted labially. So root is pushed labially. So these are the things you need to focus on when you look at this particular question. So now you have this case, and what are you going to do with this case? Whether you are going to extrude the option A says whether you are going to extrude the tooth orthodontically, whether you're going to pull it orthodontically, or you're going to put an incision over there and surgically extrude the particular tooth, or you're going to just wait and watch, or it's you'll probably consider that it has done a lot of damage, so just pull it out or extract it. So what are you going to do? So in this particular case, you are going to do nothing but wait and watch. So the correct answer here is wait and watch. So why? Let us understand. So when we talk about intrusive luxation or intrusion, that means a tooth being pushed inside. Intrusion means a tooth being pushed inside due to trauma. So in this picture, you can see that this is a permanent tooth bud. So this is a permanent tooth bud. So this is a far better diagram than what I had drawn. So this is a permanent tooth bud. This is the primary tooth that has been intruded. Okay, so the first thing that you can see here is, or just see over here, so this has intruded and the root has been tilted labially. So the root is tilted labially. What you can see here is you can see the bleeding areas over here, which shows that the first thing that has happened is that the periodontal ligaments has been severed. So when you see clinically, hardly any part of the tooth is visible in the mouth. Okay, most of the part of the tooth has been pushed into the socket. So one, clinically the tooth is not visible now, or very small part of it is visible. Second, the periodontal ligaments are severed and the tooth has attained a new position. So in this case, what you will do is you are going to just wait and watch. This particular tooth is going to develop new periodontal fibers in its new position, and the eruption of this particular permanent tooth is going to push this particular primary tooth into position gradually. So you do not need to pull it, you do not need to extract it, you just have to wait and watch. The push of the permanent tooth bud is going to get that primary tooth into position. So if you want, want, in the comments, please just mention. I am going to give you the entire link of this particular revised IADT guidelines, which gives beautiful guidelines on almost all dental traumas about extrusion, intrusion, avulsions, crown fractures, complicated and uncomplicated, the root fractures. It's a beautiful article that gives good guidelines about the treatment planning and follow up and the prognosis of various dental traumatic injuries. So if you want to go through that article, just write it in the comment section, and I'm going to share you the link of that particular article. So according to the revised IADT guidelines, if there is an intrusive luxation of a primary tooth, what you are supposed to do is, so if there is a clinical finding that says the tooth is usually displaced through the labial bone or plate and it can impinge on the permanent tooth bud. Okay, so it generally goes towards the labial plate. So what you need to do is you take radiographs and everything, and when you look at the treatment, the tooth should be allowed to spontaneously reposition itself. Do not disturb the tooth. Let it spontaneously reposition itself into the new position, irrespective of the direction of displacement. Okay. Spontaneous improvement in the position of the intruded tooth usually occurs within 6 months. So this, you can also get this as a MCQ or as a question. How much time does it take for an intruded tooth to come out into its proper position again? So it takes around 6 months. In some cases it can also take up to 1 year. Okay, so if you have an option that says 6 months to 1 year, so now you know if a tooth is intruded and you just wait and watch. So for how much time to wait and watch? It will take around 6 months to 1 year to come back to its original position. So then later, this is again a very important thing that the IADT article shows, that is, what is the favorable and the unfavorable outcome. Like, if you just leave the tooth where it is, what to expect, and when do you know that the case has gone bad? What is the unfavorable outcome? So the first favorable outcome is that the tooth is asymptomatic. The tooth is silently lying there. The patient does not complain of any pain. There is no formation of abscess or anything. So that means the tooth is asymptomatic, which is a favorable outcome. Pulp healing is with normal color of the crown or transient red, gray, or yellow discoloration and pulp canal obliteration. So basically, an unfavorable root canal will, an unfavorable case or an unfavorable outcome will show a grayish or blackish discoloration of the tooth, which will mean that the pulp has been necrosed. So if the tooth crown is of perfectly all right color, that means the pulp is in perfectly all right condition. So there has to be no signs of pulpal necrosis or infection. The continued root development takes place. There is periodontal healing, re-eruption, realignment, everything. So that's a favorable outcome. In case of an unfavorable outcome, so we have a tooth or a case that becomes symptomatic. The patient conveys a symptom of pain or probably a development of a sinus tract or swelling, etc. So there is a development of sinus tract, gingival swelling, abscess, or increased mobility, and there is dark black or gray discoloration of the tooth. So this is an unfavorable outcome. Okay, so now you know that when we are talking about the intrusive luxation of a primary tooth, you need to do nothing but wait and watch. So just go through this article. You are going to get a good amount of information about all the dental traumatic injuries in this article. Okay, so I hope that was clear. The second question that comes is, a child with avulsed permanent tooth. So the permanent tooth has avulsed. Okay, so there's a child who has a permanent tooth that has come out in toto, or it has avulsed, comes in 20 minutes with the tooth in the milk. So why am I underlying these things? Because this is how you need to analyze the questions. You need to know where to focus, and when you focus on these particular important points, the answer is going to automatically come. Especially for clinical based questions, it is very important to look into these small things, or small hints that they've given. Okay, so the tooth has avulsed, the patient has come within 20 minutes, he's rushed to you and he's kept that tooth in the milk. So the one thing that is not clear, we know that the tooth is permanent, but when you say the tooth is permanent, we do not know whether the apex of the root is closed or open. So you need to choose an option that goes unbiased, or whether it is closed or open, you do not know. You consider consider a treatment for the answer that suits both kinds of apices. Okay, so the first option that is given is rinse with saline, reimplant, and splint. So you take the tooth out of the milk, you rinse it with saline, replant, and splint it. The second option is curettage. That means you clean the tooth nicely, you curettage, you reimplant, and you splint it. The third is you clean with hypotonic solution, replant, and splint. And the last option says that you just throw the tooth away. So, one thing we know, the last option is not a very great option. So, let's not consider that. The correct answer to this question is rinse with saline, replant, and splint it. Okay, so one thing, whenever you get an avulsed tooth, so if the patient is getting the tooth in a biological storage media, that is milk, okay, within 20 minutes, okay, so yeah. So if the patient has got it in a biological storage media within 20 minutes of time, so that's a very great opportunity that will have a very great prognosis if the tooth is replanted back. So one thing we need to take care of is that since the tooth has been put in a biologic media, the PDL of the avulsed tooth must be viable. The PDL might not have been necrosed or severed, so the PDL is viable. So curating it will actually just pull off all the PDL that have been severed or cut or damaged, so just not don't curate it. So you just rinse it with saline, replant it, and splint it. You do not have to clean it with a hypertonic solution again, because that is going to trouble or destroy the PDL fibers. So the best option here is you just rinse it with saline, replant, and splint it back. Okay, so according to the guidelines, we have two conditions. That means, since it has not been mentioned in the question whether the permanent tooth had an open apex or a closed apex, let us just go through what we do with either of these in either of these situations. So if we have an open apex of an avulsed tooth, what you do, either the tooth is immediately replanted. Okay, so if it is immediately replanted, you splint it for approximately 2 weeks. So you splint it with approximately 2 weeks, and 4 weeks for dry time greater than 60 minutes. Okay, so either you splint it splint it for 2 weeks, and then in that much time it will develop new PDL fibers. If there has been a dry time more than 60 minutes, then you splint it for 4 weeks. So when we talk about the dry time, that means if there has been an extraoral storage time which is between 20 to 60 minutes, whether if it has been stored in HBSS or milk, that is a biological storage media, then you soak it in doxycycline in order to just remove if there is any bacterial contamination around the tooth. And then and then since there has been a dry time, so you splint it for 2 weeks in case the dry time is less than 60 minutes. If it is more than 60 minutes, then you splint it for 4 weeks. But when the dry time is greater than 60 minutes, what you do first, you deliberately remove the periodontal ligament and then place it in 1.23% sodium fluoride in order to make it resistant to external resorption, pathological resorption, and then you splint it for 4 weeks and do an endodontic therapy. So here you need to do an endodontic therapy. Okay, and with all of these you need to run an antibiotic dosage for 7 days and then you follow up after 7 to 10 days. Right. This was for the open apex. So since there is an open apex, the endodontic therapy will include either regenerative procedures, or it is going to include apexification as a procedure. Clear? Now, when we are talking about the closed apex, the one thing that you need to do an endodontic treatment for whatever case you have. So, if there is a closed apex, and either if you've replanted the tooth immediately, or there has been a biological storage media time greater than or less than 60 minutes, you ultimately replant it, splint it, and do an endodontic therapy. Am I clear? Now comes the third question, which is primate space in maxillary arch is present where? Okay, so you've been asked about primate space in the maxillary arch. So, as we've read, there are primate spaces in the maxillary and mandibular arch of the primary dentition, which are also called as the anthropoid spaces or the simian spaces. So these are the naturally occurring spaces in the primary dentition. Okay, so these are present in maxillary and mandibular arch. So when we talk about the maxillary arch, so M for maxilla, and mesial to the canine here in the maxilla. That's how I used to learn this. So in the maxilla, I held on to M. So M means mesial to canine. And in the mandibular, though it also starts with M, but it has a D. So in the mandibular, it is distal to canine. So the primate spaces in the maxillary arch are mesial to canine, which makes this the correct answer. And when we talk about distal to canine, so we are talking about the mandibular arch. Okay, so I hope this is clear. M, say maxilla, so mesial to canine. There is a D in mandible, so distal to canine. That's how the primate spaces are present. So basically, how much they are? So the total space. Yeah. So the total space may vary from 0 to 8 mm with an average of 4 mm in the maxillary arch and 1 to 7 mm in the mandible with an average of 3 mm in the mandibular arch. So 4 mm in the maxillary arch and 3 mm in the mandibular arch. The fourth question is first sound that a child makes. So there are various types of sounds, and the first one that a child makes is which of these? Option A is bilabial sounds. Option B is labiodental sounds. Option C is linguodental sounds. And option D is palatolingual sounds. So, the most easy to utter amongst these sounds and the first to develop in a child are the bilabial sounds. So, when you say bilabial, that means sounds that are made using only the two lips, like, for example, M or M and P. So it's a very emotional moment when a child starts saying ma or papa, so it is because these are the easiest sounds to be made, and these are the first sounds a child makes. So that is m and p, things like that, which are made using the two lips. That's why they are called as the bilabial sounds. Now there are various other sounds, like the options that are given. The labiodental sounds are like the f, or v. So labiodental, that means sounds that are uttered using the lips and the teeth. So when I say f, that means I am using or I am touching my lips and my teeth. So it is f or v. So these are the labiodental sounds. Then we have linguodental sounds where I touch the tongue and the teeth. So these are sounds like th. Okay, so when I say th, that means I'm using my tongue and my teeth. And there are the palatolingual sounds, that means sounds that are used with the help of connecting the tongue, that is lingual, and palate. So these are sh and z. So in these there is a use of the palate and the tongue. Okay, so these are the, and as I told you, ma and ba are the bilabial sounds, which are the first sounds that a child develops when he learns to speak. So there are various milestones if you look at it. So when the child is of 1 month old, so he learn to turn his head to sound. Like if you'll clap, or you'll just use a rattle toy to make some sound, so the child might turn the head towards the sound when he's 1 month old. So again, these milestones might vary, but I'm just telling you an average age, like when do generally children start doing this. So when he is 3 months old, he'll start cooing. That means making those baby sounds that small children make, the infants make. That's called as cooing. When he is around 6 months, he will start using the monosyllables like ma or b. Okay, he'll just say ma or ba, and he might not say mama or papa, just start saying ma or ba. Then when he is 9 month old, he might start saying the bisyllables, that means mama or baba. Okay, then when he is 12 months old, he might say two words that have meaning. And then 18 months, 24 months, and 36 months, he'll start telling stories and making stories and stuff. So these are the milestones, but the easiest sounds, as I told you, to utter are the bilabial sounds, and those are the first sounds that a child starts speaking. Right? The fifth question is, which of these is not an EAPD criteria? So that's European Association of Pediatric Dentistry criteria for MIH, that is molar incisor hypomineralization. So the options that they've given is, so what they've asked is not an EAPD criteria. Okay, so the options that they've given are sensitive teeth, opaque teeth or opacity, atypical restoration, and enamel breakdown. So when you look at the EAPD criteria of MIH, you will see the numbering from, or scaling from 0 to 10, in which you have enamel defect free, then there are demarcated opacities with no post eruptive breakdown, with post eruptive breakdown, and everything. So you can go through this entire criteria, but the one thing that is not included in this entire criteria is sensitivity. Okay, so you have these options, that is opacity. So they are talking about opacities over here, demarcated opacities. Then you have an option atypical restorative breakdown. So there are atypical restorative breakdowns in this. Okay, so there is atypical restorations also, and then enamel breakdown. So there is a post-eruptive enamel breakdown over here. So you have all of these three except for sensitivity, which is not included in the MIH EAPD criteria, right? Then we have the sixth question, in which they have asked, in this image below, which is of a 5-year-old child, so it is a 5-year-old child image, identify this caries type as per the Bangkok classification of caries. So the moment you look at this picture, you know this is severe ECC. But when you read there is a Bangkok classification, you might, get confused. Like, is it something else? What does the Bangkok classification of caries say? Because most generally you don't come across the Bangkok classification. So the answer undoubtedly here is severe caries, whether it is Bangkok or Singapore or whatever classification. This is severe ECC. But why is it called as the Bangkok classification? Because The International Association of Pediatric Dentistry held a conference in Bangkok. Okay, so the International Association of Pediatric Dentistry held a conference in Bangkok on ECC. So this conference was exclusively on ECC, held in 2018, to give a global perspective on the definition, etiology, and current concepts, and the risk assessment and management of ECC. So since this exclusive ECC conference in 2018 was held in Bangkok, which gave a beautiful definition to ECC and various etiology, the current concepts were discussed. Hence, they proposed a classification that was called as the Bangkok classification of caries, which is exactly the same as the earlier one. So do not worry, when such a picture emerges, it is undoubtedly severe early childhood caries. So in this expert conference, there was an expert panel which defined ECC as. So how was ECC defined? It is a biofilm mediated. So it is caused due to the deposition of biofilm for a long time. Sugar driven. Sugar acts as a criminal along with it. Multifactorial. There are other factors also, like decreased immunity or improper hygienes. Hence it is multifactorial. Dynamic disease. Dynamic, that means which is always in action. It is never dormant. It is a dynamic disease that results in phasic demineralization and remineralization. So this is going to cause demineralization, and poor saliva will try to cause remineralization of dental hard tissues, determined by biological, behavioral, and psychological factors linked to the individual's environment. So this was the definition that included almost everything about early childhood caries, which was proposed by the expert panel in the conference held in Bangkok in 2018. That's clear. So also in that particular conference, it was recommended that twice daily brushing in children is required with at least 1,000 ppm fluoridated toothpaste. So there are various brands that have launched toothpastes containing, for children, containing 1,000 ppm fluoridated toothpaste. So I'm not going to tell you here, but there are a lot. You just go Google search. So according to this conference, it was recommended for the children to use 1,000 ppm fluoridated toothpaste at least twice. Brushing is required, and using age appropriate amount. So when we talk about age appropriate amount, if the child is below 3 years, then a smear should be applied. A smear of toothpaste should be used on the toothbrush for brushing. And if the child is above 3 years or 3 to 6 years, pea-sized amount should be used. So below 3 years, that means smear layer of the toothpaste, and more than 3 years age, that means it should be a pea-sized toothpaste. Is it clear? So this brings us to the next question, which is the 7th question, again a clinical or an image based question. So here, take note, an 8-year-old boy with a fractured maxillary central incisor is seen in the image, who reported 72 hours after the injury. Match the type of tooth with the tooth with fracture with the correct treatment. So you need to look at the x-ray, the clinical picture, and you need to tell the treatment. Okay, so when you look at the x-ray carefully, see, this is a fractured central incisor. But when you look at the x-ray, you see that there is a small or a good amount of layer of dentine above the pulp. So clearly, this fracture is not involving the pulp. So when a crown fracture not involving pulp. So when a particular fracture does not involve the pulp, it is called as an uncomplicated crown fracture. Okay, so when we say that it is an uncomplicated crown fracture because there is no pulpal involvement, so we can cross A option and the D option, because both of them say complicated crown fracture. But clearly this is an uncomplicated crown fracture, because the pulp seems to be safe. It is not involved when you see the x-ray. So uncomplicated crown fracture, the other two options say an uncomplicated crown fracture requiring non-vital pulp therapy, and C says an uncomplicated crown fracture requiring vital pulp therapy and reattachment. So the answer here goes an uncomplicated crown fracture requiring vital pulp therapy and reattachment. So why non-vital pulp therapy is not required? Because the pulp is not involved, so there is no necrosis of the pulp that has occurred, plus there is an open apex as you see in the x-ray. So what you can do, you can just do a vital pulp therapy like apexogenesis or pulpotomy, and that will result in continued development of the root, and you can reattach the separated tooth structure, or you can just do a composite restoration there. But the tooth from inside is perfectly all right, and you can do a vital pulp therapy like a pulpotomy or an apexogenesis. Is that clear? So that makes C as the correct option for this. Clear? This brings us to the 8th question. In this, they say, in the image below, identify the procedure that is being done. So this is the image. You see a tooth with a slightly open apex, because the you can see the whatever material this is, it is over here. So the apex is slightly open. Clear? So there's a slightly open apex. These hands that you are seeing here are that of the rubber dam. So you don't need to think about it. Rubber dam. Okay, so what is this particular thing over here? So this procedure that is being done is an MTA apexification. MTA apexification. It is not a root canal treatment. Why? Because the apex is open, and in the root canal treatment we don't just fill that much part, we fill the entire root canal. So plus the apex is open, as I am stressing again and again. So it's not a root canal treatment. It's not apexogenesis, because you see if there is a filling over here in the apical third, that means this entire area is empty. So apexogenesis is a vital pulp therapy, and there is no pulp only in the canal, so it is not apexogenesis. It is not root end filling, because for root end filling, this place should not be empty, it should be filled, and then you do a root end filling. And then the option we are left with is an MTA apexification. So this is an MTA apexification procedure. In this canal, they have placed MTA at the apical end, so that the apex gets sealed, the apex gets fixed, and in this much area now they are going to put gutta percha, or they are going to put a normal obturating material. So this is an MTA apexification. So here, since the tooth is non-vital, since the tooth is a non-vital tooth, so the treatment opted will be apexification. So you know what is apexification? One thing I want you all to know is, so the process of MT apexification involves placing the MTA plugs in the apical portion of the canal with a thickness of 3 to 5 mm, followed by conventional root canal obturation with gutta percha. So 3 to 5 mm of the apical root, you place MTA there so that the apex gets sealed, and then you use a conventional gutta percha to seal the rest of the canal. Clear? This gets us to the 9th question, which is, which of these is not a risk for dental trauma? So when we look at the options, proclination of incisors. So when the incisors are proclined, they are at a risk of dental trauma. If the child falls down, or if he or she hits the face somewhere, so the first thing that is going to come in contact and get traumatized are the incisors if they are proclined. So proclination of incisors is definitely a risk factor for trauma. Increased overjet is again the same meaning. Increased overjet means proclination of incisors. Physiologic space. Okay, so physiologic space, there is no, there is nothing, no reason why physiologic space can be at a risk for trauma. Short upper lip, on the other hand, can be again a reason for trauma. When there is a shorter upper lip, the incisors are at a greater risk to get traumatized, because again, the whole cycle, shorter upper lip, there will be mouth breathing will result in an open bite will result in proclination of the anteriors, and proclined anteriors are at a greater risk to dental trauma. So again, short upper lip cannot be the correct answer. The only correct answer are the physiologic spaces. So presence of physiologic spaces has nothing to do with the risk for dental trauma. Clear? Yeah, so there are conditions that might increase the chances of dental trauma, and they are increased overjet, protrusion of incisors, and inadequate lip coverage. Again, the medical conditions like cerebral palsy, epilepsy, cerebral palsy, hearing or visual impairments, and attention deficit, hyperactivity disorders are certain medical conditions in which the child is at a greater risk to dental traumas. Clear? Now, this gets us to the last question of the session, and that is discrepancy in the anterior primary and permanent spacing is called what? So, what is the discrepancy in the anterior primary and permanent? So, there are primary anteriors and there are and there are permanent anteriors. So, what is the discrepancy called? So, it is undoubtedly called as the incisal liability. So what happens? So we have these are the primary incisors. Okay, there are generally spaces present in the primary dentition, so I've made a little space. And then we have the permanent incisors that comes and makes the child look like bunnies. Okay, they are huge, they are greater in width and they are greater in length also. So we have this much of space available, but we have to accommodate something that wants this much of space. So this is called as incisal liability. There is a liability on the arch to accommodate huge incisors. That's why it is called as incisal liability. So how do they take care of this liability? So this has been taken care of with the help of the inclination. So apart from the the physiologic spaces are being used and everything, there is an inclination. So anything that is inclined at a greater angle will take up more space, and anything that is inclined at a lesser angle will take up a lesser space. Okay, so the primary teeth are inclined at an angle of 150 degree, and when the permanent incisors come, they are a little proclined and they are inclined at an angle of 123 degree, and that buys them a little more space to accommodate in the arch. So there is change in the incisor angulation, plus there is using up of the physiological spaces, and that is how the incisal liability is met and the incisors are accommodated in the arch. So I hope it is clear. I hope all the questions that I just explained, the explanations are clear. You are always welcome to ask whatever doubts you have, and if you need any articles to go through or any other theory book suggestions or anything, just post and I'm going to reply to you. And read well, go through all your textbooks, the standard ones, and we are here to help. We are here to solve all your queries. Thank you so much.